Good morning. Today's class is about pathology of WBC disorders. This is the objectives of my class. So first I'll be telling you about WBC in health and disease, wherein I will be discussing about what a normal WBC is, that is, what is the normal functioning of a WBC, what are the different types of WBC, and in a healthy individual, how does this WBC performance function, and if a person gets disease, how this WBC get affected, and as a result, what happens to the morphology and function of WBC. The next I'm going to discuss about the WBC disorders. So any disease we know it is of two types. One is the non-neoplastic and the neoplastic. Non-neoplastic includes any infections and inflammations, and the neoplastic conditions include the benign and the malignant one. So similarly in WBC we are going to be studying about the non-neoplastic conditions or the various conditions in which the WBC shows abnormality, which could be in the range of infections or inflammations, and the WBC malignancies, which are referred to as leukemias or the blood cancers. There is going to be a brief section where I'll be discussing in detail about that. And next, in all of these conditions, let that be a non-neoplastic or neoplastic, what are the various clinical features? That is, how does the patient present with? What is the pathogenesis? What is causing or leading to the abnormalities of the WBCs? The lab diagnosis, how do we identify? That is, just by looking at the CBC or by looking at the peripheral smear, how do we identify the condition and how it helps in diagnosing the disease? Next is on the blood morphology, which means the peripheral smear. So just by identifying the morphology of each of this WBC, how we can go in for the diagnosis of that particular disease. And last of all, just a brief note on the management. That is how each of this condition is treated. So the top 10 WBC disorders which will be discussed in the subsequent slides are: first is the leukopenia. So the term, whenever suffix penia comes, means the counts are decreased. Okay, so under the leukopenia we have neutropenia, lymphopenia, and pancytopenia. Okay, so now we all know WBCs are 5 types. Okay, what are it? Use neutrophils, eosinophils, basophils, which are referred to as the granulocytes because they have granules in them, and then the agranulocytes called as the lymphocytes and the monocytes. Any conditions where it is decreased, it is referred to as a leukopenia. That is, a whole WBC count is reduced, referred to leukopenia. And if each of the cell, like for example neutrophils are low, it is called as a neutropenia, and so on. Pancytopenia is a condition in which everything goes down. That is, the RBCs, the WBCs, and the platelets. So all the three lineages of the blood cellular elements goes down. Leukocytosis is a condition where the counts are increased. So again, similarly, depending upon which cell in the particular WBC is increased, is referred to as a neutrophilia, eosinophilia, lymphocytosis, and lymphadenitis is a condition where there is swelling of the lymph nodes because these WBCs is present in tissue. That is, in the tissue, the WBCs go in for a infection or inflammation. And then under the neoplastic disorders, that is the blood cancers or leukemias, we have two conditions called as lymphomas and leukemias. Lymphoma is seen in the tissues, whereas leukemia is seen in the blood, and it is again further classified into 4 types based on the lineage, that is cell origin, whether it is a myeloid cell or a lymphoid cell, and second type is based on the chronicity, whether it is acute or chronic. So based on this, there are 4 major types of leukemia, that is AML, ALL, CML, and CLL. This is just a nutshell of what we are going to be learning in today's class. Subsequent class I'll deal it in detail. So this is a normal peripheral smear, and we are seeing the various blood cellular elements. So now we know blood has 2 components. One is a liquid component, which is a plasma, and the cellular component, which includes 3 types of cells: RBCs, WBC, and the platelets. So these are the RBCs, which on a peripheral smear they appear spherical. That is, they are normocytic and then normochromic. In normocytic, normochromic RBCs, and the function of RBCs, we know it contains hemoglobin, which carries oxygen. Okay, so that is a normal. It carries oxygen, and therefore it supplies oxygen to the tissue and so on. So that is for the main normal function of the RBCs. And this is the refractile, the purplish structure which we see in the periphery. This is the platelets, and we know platelets are useful for the bleeding, to help in to prevent bleeding. Okay, so That is about the platelets. And WBC, we know the main function of the WBC is defense mechanism or the immunity. So whenever the host is suspected, whenever a host receives any organism like a microbe or a physical or a chemical agent, in response to that, the defense mechanism of the body, the first cell to go there is the WBC. And the WBC is of 5 types. You have the granulocytes, as already mentioned, the neutrophil, the eosinophil, and the basophil, and the A granulocytes, like I've mentioned, the lymphocytes and the monocytes. So now we should know the morphology of each cell. That is, the neutrophil, which you see over here, it has whenever you describe a cell, there are two components. One is the nucleus and the cytoplasm. Okay, so in the neutrophil, we'll see the nucleus. It is 2 to 5 lobed, and the cytoplasm is moderate amount of cytoplasm, and it has lilac or the mauve colored granules. So you can see this. These are the lilac or the mauve color granules, or lavender or the mauve color granule. And the normal differential count of the neutrophil is anywhere between 50 to 70%. When I say differential, what I mean is that on a peripheral smear, if I'm counting 100 WBCs, the percentage of neutrophils to be present in that particular in that 100 WBCs around 50 to 70. So that is the differential of the neutrophils on a WBC count, which is around 50 to 70%. The second cell which we see here is the eosinophil, which is again the granulocyte, and we can see it is a bilobed or spectacle shaped nucleus, and you can see it has crimson red or pinkish, dark pinkish colored granules, and this is the differential count of an eosinophil on a slide is around 2 to 6%. And the last of the granulocytes is a basophil, which has coarse purplish granules. So you can see these granules, so much so that the granules completely obscure, or they completely cover the nucleus, that we are not able to visualize the nucleus at all. Only the granules will be seen. And the differential count of a basophil is around 0 to 1%. So the neutrophil, eosinophil, and the basophil. And on the agranulocytes, we have the lymphocytes, which has a centrally placed nucleus and a thin rim of pale bluish cytoplasm, which is devoid of granules. Okay, and based on the size of lymphocyte, there are 2 types: small lymphocyte and the large lymphocyte. And this, the largest of all the WBC, is the monocyte, which is a large cell, and it has a kidney or a reniform shaped nucleus and moderate to abundant cytoplasm but devoid of granules. So in this blood smear, you can very clearly identify the 5 types of WBC, the morphology of which, and I've also mentioned to you what is the normal differentials in a normal differentials when you do a count of 100 WBC. Also, we notice what is how does the RBC look like and how a platelet looks like on a peripheral smear. Moving on to the next slide, very important slide which you must remember, the normal counting. Okay, so certain things you have to memorize, and this is one of the things where you have to know the normal counting of the WBC and the differential. So WBC count, the normal count is 5,000 to 10,000, and the differential count, neutrophil as already mentioned, 50 to 70%, eosinophil is 2 to 6, basophil is 0 to 1%, lymphocytes are 20 to 40%, and monocytes are 2 to 10%. So this is the normal differential. So when you count 100 WBC, this is the generally split up of each cell in a normal individual. So moving on to the next slide. So this slide tells us about the production of WBC. Okay, so the primitive cell, or the first cell from which each of the cell WBC rises, is what is referred to as the myeloblast or the myelomonoblast. So this is the myelomonoblast, which is the most primitive cell, and from the myeloblast develops the promyelocyte, the myelocyte, the metamyelocyte, the band form, and then finally it forms a mature neutrophil which circulates in the blood. Similarly, from the myelomonoblast develops the monoblast, develops a promonocyte and the monocyte which circulates in the blood. So in the myelocyte lineage, depending upon what granules it is, it divides here into the basophil, eosinophil, and neutrophil. So at this stage, there are 3 divisions, and neutrophils, basophils, and eosinophils come here, and from myelomonoblast, the monocytes here, and there is a separate blast called as the lymphoblast, which gives rise to lymphocyte, and the lymphocytes enters into the blood. Now, why I am telling you about all this immature cells, okay? So now all this you can see is present in the bone marrow. So bone marrow is the site where the production of cells takes place, okay? So and all the immature cells are produced in the bone marrow. Anytime you see immature cells in the peripheral blood, in the circulating blood, it indicates severe infection, inflammation, and if the count of these immature cells is really high, then it indicates leukemia, because immature cells are supposed to be present in the marrow, they mature, and then they're released into the blood, and then they do their functioning. If these immature cells get into the blood, they do not know what function to do. They just occupy the complete space, and they're completely useless, causing the person the main function of WBC. What is the function of WBC? Defense. The defense mechanism of WBC is lost, okay, leading to various infections and diseases in the person or in the host. So that is why the blast should be, or the immature cell should be present in the marrow, and they're not to be present in the peripheral blood. So whenever the immature cells are present, it is what is referred to as a left shift. Now this is a slide extremely important. This tabular column is given in most standard textbooks, and this is something which you have to remember. So what do you say, that make your own chart, write it down in your notebook or whatever. For each case, that is penia, I've already told you, when the suffix penia comes, which means the count is decreased. When the suffix philia comes, it means the count is increased. So here we are just seeing the each of the leukocyte, like the neutro, yes, no, mono, lympho. In each of it, when the count goes down, what does it indicate? What could be the most common differentials? Similarly, the other end, the other range, when the count increases, what are the common conditions where it can be seen? Okay, so just by simply looking at the WBC count, and then by doing the DC, we can very easily identify what could be the differentials in that patient. Also here, what you have to notice is something called as the absolute count. So when I say absolute neutrophil count, what I mean is the DC of the neutrophil, okay, that is how percentage of neutrophils which are present, divided by 100 into the total count of the patient. For example, let's say we are seeing around 90% neutrophils, okay, and the total count of the patient is say around 15,000. So it becomes 90 divided by 100 into 15,000, okay, and there is a cutoff range for each of it, which you should know, and when it is above that, it is referred to as absolute neutrophilia, okay. So there is certain terms called as a relative neutrophilia, and there is something called as a absolute neutrophilia. So so certain conditions, you please so I'm just going to tell you about what are the conditions which are seen in the different penias and philias. So in neutropenia, whenever there's neutropenia, you have to think about congenital neutropenia, the acquired neutropenia, severe infections, splenomegaly, post chemotherapy, drugs and toxins, or the marrow goes in for failure. Whenever there is neutrophilia, which means the count is increased, where do you see it? Is infections, trauma, post-steroids, any metabolic disorders. So in all these conditions, you see neutrophilia. Similarly, in eosinopenia, you see is in certain bacterial infections, post-ACTH administration, and eosinophilia, you see in hypersensitivity reactions, drug therapy, pulmonary diseases, parasitic disease, and certain myeloproliferative disorders like CML. Monocytosis, sorry, we'll go to monocytopenia. You see it in post-corticosteroid therapy and a condition called as a hairy cell leukemia. And monocytosis, that is increase in the monocyte count, you see in post-mycobacterial infections, in subacute bacterial endocarditis, certain myeloproliferative disorders. Lymphocytosis, you see it in viral infections, certain fungal parasitic infections, drug hypersensitivity, and certain immunological diseases. By and large, remember viral and fungal infections. And lymphocytopenia, you see in congenital immunodeficiency, disorders like HIV/AIDS, post-drugs like corticosteroids, GI disease, and the most often talked disease right now is the COVID. Even in the COVID-19, we typically see a lymphopenia. So the patient's presents with a leukopenia, and typically they will have a lymphopenia because the lymphocytes are dropped, and that is why the person presents with host of infections. Okay, so this is the chart where you should remember where what in conditions where the counts are decreased, counts are increased. Please try to remember at least 4 to 5 in each category and try to memorize them. Next, just summarizing again. So I've told you whenever the WBC count is decreased, call as a leukopenia, and if the neutrophils are reduced, it is referred to as the neutropenia. So now this can be seen in whenever the marrow is hampered. That is, marrow is a problem because that is a production site. So the production site is having some problem and definitely go down. So problems with the marrow, or in the periphery, some destruction is taking place. That is, it enters the blood, but it is getting destroyed, which could be because of immune mechanism, that is antibodies are destroying it, or because of drugs. So these are the common cause of neutropenia. When it is extremely severe, it is referred to, there's a condition called as the agranulocytosis. So whenever the person is having neutropenia, the function of neutrophils or WBC is to fight infections, but if they're not enough amount of neutrophils are not there, the person is not able to fight the infection, and the patient presents with chills, fever, fatigue, ulcers. So all these are the very common presentation of a person with neutropenia. So leukocytosis, which means count is increased. Okay, so when do you see increased count? We can see in the cases of acute inflammation, or we can see it in the cases of bacterial infections. And when it is very severe, that is, what is the normal count? I told you 4 to 11,000. Okay, when the count is extremely increased, that is more than 11,000, sometimes in leukemoid reaction it can go up to 50,000. Okay, so in extreme infections and inflammation, that is what is referred to as the leukemoid reaction. So now this is a picture of neutrophilia. So you can see all these are the mature neutrophils. They're really abundant. This is an eosinophil. These are really abundant in number. So ideally on a smear we'll see maybe 2 or 3 in one particular zone. But here you can see the count is really increased. That's why you see so many neutrophils. And here we can see the toxic granulation left shift, which again say that they have tried that there is some amount of infection or inflammation going on, because these granules, can you see this? If you see the previous slide, it's just like hard, very lavender, light mauve colored granules. Okay, but here you can see they are really toxic. Okay, so toxic means which are the darkly stained, dark colored thing, because they're really active. They're liberating the enzymes to fight the infection. So this is called as a toxic granulation, which is very significant of acute inflammation, and could be bacterial, immune, or due to trauma, whatever be the reason. Whenever there's an acute inflammation of the body, these toxic granulations can be seen in the neutrophils. And I mentioned to you, when it's very severe, that is leukocytosis is extremely severe, that it's more than 50,000 that is cells per cubic millimeter of blood, it is referred to as a leukemoid reaction. It is seen in severe infection, trauma, bone marrow infiltration. So here you can see all the cells. There can be a significant shift. So if you remember the production of WBC, I told you about all these immature cells. So there could be immature cells, like we can see metamyelocytes, we can see myelocytes, promyelocytes, but very occasional blast. Okay, very rarely, say 0 to 1% you'll see blast, or most often 0%. Okay, so that is because there'll be a shift, but the blast is generally absent in leukemoid reaction. And so this, when we have the suffix moid, which means it mimics leukemia, but it's actually not a leukemia. That's why we call it as a leukemoid reaction. Okay, because so many cells will be there, there'll be a nice shift to left, but what is absent is the most immature cell, the primitive cells, the blast are typically absent. That's why it is referred to as a leukemoid reaction, and this is completely reversible. That is, once the patient is out of the sepsis, out of the infection, inflammation, the counts come back to normal. Okay, but leukemia, there's a problem with the stem cell, and if the patient needs treatment, because it is a blood cancer, so therein you have to go in for therapy. That is either a chemo, radio, a stem cell transplant, whatever. Based on that leukemia, you have to give treatment. But leukemoid reaction, just treat the infection, inflammation. It's temporary. The patient gets back to the normal count and normal morphology. Now this is lymphocytosis, where you can see in conditions like infectious mononucleosis or chronic inflammation, viral, fungal, and tuberculosis. So here you can see a reactive lymphocyte which is very large. You can see this more amount of cytoplasm and the typical round shape of the nucleus is lost. You can see blebbing, a lot of blebbing can be noted over here, that is, and some finger-like projection. So this is a reactive lymphocyte. Okay, so that finishes the non-neoplastic. So we have dealt and we have seen about what are the conditions in which counts are decreased, counts are increased, what is leukemoid reactions. So basically everything non-neoplastic or just or the non-malignant conditions. Now we are going to start with hemato-oncology, or which means cancer of blood. So cancer of blood is referred to as a leukemias, and typically the cell which is involved is the stem cell or the blast. So if you remember the most primitive cell in my first slide, so that is a cell which causes the leukemia. So it starts in the bone marrow or lymphatic tissue, and then from there it spreads to the blood and other RES, which is the reticuloendothelial system, which includes the liver, spleen, and lymph nodes. And there are two major types based on the cell lineage. If it arises from the myeloid or the myeloblast, it is a myeloid leukemia, and if it arises from the lymphoblast or the lymphoid lineage, it is called as a lymphoid leukemia. And two clinical presentations are there: acute and chronic, based on the chronicity. If the symptoms occur and the patient presents within 3 weeks, it is referred to as an acute. Chronic means the patient will have maybe harboring the infection, harboring the cancer for like years together, but it will be very indolent, and after many years the patient will present with the symptoms. So that is called as the chronic leukemia. So again, this is just so for to diagnose a leukemia, you need three things. First, evaluate the clinical history. Second is you do a peripheral blood smear and you should identify blast. Third is you do a bone marrow, again to identify leukemia and to classify what type of leukemia is it. And then there are a lot of advanced technology like flow cytometry, cytogenetics, which can be done to identify the subtype the leukemia and to go on for the treatment of the patient. Okay, so similarly, if the WBC, if it is present in the tissue, that is what, and they go in for neoplasm, that is referred to as a lymphomas, so which is seen mostly in the lymph nodes, or it can be also seen in the spleen and liver, and it is of basically of two types, Hodgkin's and the non-Hodgkin's lymphoma. Okay, and certain pre-malignant conditions are the MPD syndromes, that is myeloproliferative syndromes, and the myelodysplastic syndromes, which can proliferate later and develop into the leukemias. So what does a patient present is with? What happens is, all I told you, leukemia is nothing but the bone marrow and this peripheral blood is flooded with the immature cells, which are the immature WBCs. So obviously, because these WBCs are immature, they cannot function. So when they cannot function, what happens? The person becomes susceptible to infections. The person will be having increased episodes of infection, bacterial, fungal, or viral. Similarly, what they happen is, because so many immature WBCs are, they suppress the normal production of platelets and the RBCs. So when their functioning is depressed, what happens is anemia. Because RBCs are less, it results in anemia, decreased oxygen carrying capacity, hypoxia and its complications, and because of decreased platelet, it causes bleeding. So we know platelets helps in the clotting cascade and helps the blood to helps in the preventing the bleeding. So person has a lot of bleeding. So these are the most common clinical features with which a person with leukemia will present. Also, the person can also have bone pains, and because of the extraosseous hematopoiesis, that is at all reticuloendothelial system can be involved, it results in splenomegaly, hepatomegaly, and lymphadenopathy. So this is the clinical pictures where you can see the person is having a lot of multiple reddish spots on the skin. This is called as a petechia. Because of the excessive bleeding, the person is not able to stop, platelets are not there, it's not able to stop the bleeding. And here you can see lymphadenopathy, and here on the tongue you can see these whitish patches are nothing but the candidiasis, because the person is prone for infection. So this is a type of a fungal infection. And here you can see this hepatosplenomegaly, enlarged liver, enlarged spleen. So massive hepatosplenomegaly may be noted. So again, acute leukemia, I told you it's from weeks to months, and AML is again classified from M0 to M7 based on the FAB, which is the French American British classification. And you really don't have to know each subtype and what is the morphology, what is the cytochemistry, but at least know the classification in general. You know how many types of AML are there. So all just the overview you must know at your level. And acute lymphoid leukemia, ALL, it has many subtypes, L1, L2 and L3. So AML as a by and large is seen in adult population, whereas ALL is seen in children's. Okay. Chronic leukemia patient presents after years, and the CML is seen in adults, and CLL is seen in generally it's a disease of the elderly or older people are present with CLL. So this is a classification acute myeloid leukemia proposed by the WHO, where it is classified as AML with recurrent chromosomal rearrangements with multilineage dysplasia, therapy related and not otherwise specified, which includes the FAB classification of M0 to M7. So this is just for desirable to know such things. And this is the ALL classification, where it is classified L1, L2 and N3. And there's another one, this is based on the morphology and again based on cytogenetic and immunological criteria. It is classified as pre-B-ALL, B-cell and T-cell ALL. So this, I just wanted to show you one picture in AML which you typically see is the presence of these blasts. Okay, so this is the blast, which are nothing but the large cells. They will have a very thin rim of cytoplasm and generally very few granules will be seen. What you typically see is the presence of nucleoli. So you take all these cells, here you take this presence of 2 to 4 nucleoli can be seen in a myeloblast. So here can you see, here again nucleoli. So these are all examples of myeloblast. So this is just for you to identify that if you see many blasts in the smear, please immediately think of some leukemia, and again then you need to look at the morphology of each blast to subclassify it into AML or ALL, or if it is AML ALL into M0 to M7 or from L1 L2 L3. But identification of a blast is very important. So at your level, so when you see a slide, at least you should know and tell that it is a blast. Now coming to CLL, I told you generally presence in the elderly. They will have a lymphocytosis, and if you do a absolute lymphocyte count, it is more than 5,000 cubic millimeter, 5,000 cells per cubic millimeter of blood. And what you see is a mature small lymphocytes. You will see mature small lymphocytes, and also you will see what is referred to as a smudge cells, because these lymphocytes are extremely fragile. When you make the smears, they just break off and they result in the formation of smudge cells. So they will not have any blasts and all. They will just have mature small lymphocytes and smudge cells. Okay. Now there is the myeloproliferative disorders, which includes 4 types: polycythemia vera, CML, essential thrombocythemia, and myelofibrosis. Under this comes the CML, which is a myeloproliferative disorder. CML generally peaks at around 50 years of age. Here again we will see leukocytosis. What we'll typically see, this is shift to left. Okay, so just like a leukemoid reaction, we will see a massive shift to left will be there, but the patient will definitely have blast. Remember what I told in leukemoid reactions, it's generally 0 to 1%, or rather you can say no blast at all, but in CML definitely there will be presence of blast. So a very close DD for CML is the leukemoid reaction, and where you do something called as lab score, which is positive in leukemoid reaction, and the lab score is negative in the CML. So lab score is nothing, it stands for the leukocyte alkaline phosphatase. So here another one important thing which you see in CML is there is thrombocytosis. In all leukemias, if you remember, I told you that the platelets are reduced, or are not, platelets are generally reduced, but in CML, the platelets are either normal or the platelets are increased. So thrombocytosis. And important, you will also see the presence of eosinophilia and basophilia. So these are very characteristic features which you see in CML. So based on the age and on the clinical features, you will see a massive splenomegaly. Hepatosplenomegaly can be noted, and there will be leukocytosis which shift to left with thrombocytosis, eosinophilia, basophilia. And for diagnosis, you need to do a peripheral smear and bone marrow. And important thing you have to do is the cytogenetics here, because you need to identify something called as the Philadelphia chromosome. Okay, this Philadelphia chromosome is nothing but there is a reciprocation translocation of the BCR-ABL gene, and if you identify this Philadelphia chromosome, this targeted therapy can be given, and it can be the patient can be treated accordingly. So there's a drug called as imatinib, which acts on the tyrosine kinase, which encodes for the BCR-ABL translocation, which is seen in Philadelphia chromosome. So remember, the Philadelphia chromosome is is very important to be identified by the cytogenetics in a patient with CML. Now, differential diagnosis, I've already told you about it, the leukemoid reaction, and you can differentiate by using the alkaline phosphatase. So this is a picture of CML where you can see there's a nice shift to left will be there, and there's a presence of blast. Okay, so this blast is extremely important for the identification of CML. So this is just a normal picture where you can see all normal. This is a lymphocyte, this is a neutrophil, the normal RBCs, and here you can see so many blasts. In AML, the whole thing is so many blasts, whereas in CML you see generally the mature neutrophils will be seen, and in this picture there is no blast, but they will see blast, you will see eosinophilia, you will see basophilia, and also you will see thrombocytosis. So I told you tumor of the lymphoid tissue, that is the lymph nodes, is referred to as a lymphoma, and generally it is of two types, Hodgkin's lymphoma and the non-Hodgkin's lymphoma. The typical cell which you see in the Hodgkin's lymphoma is the Reed-Sternberg cells. So all this will be seen in the subsequent slide, but this is just to complete the topic of the overview of WBC disorders that I put up this slide. So you should know about the Hodgkin's and the non-Hodgkin's, and they will have massive enlargement of the lymph nodes. You can see here such a big lymph node. So the lymph adenopathy is a characteristic feature. So to summarize today's class, we initially studied about the reactive conditions, where we studied about the different leukocytosis, the leukopenias, and then we discussed about the leukemias, the 4 types of leukemias, and then we had a slide discussing about the lymphomas of and the 2 types, the Hodgkin's and the non-Hodgkin's, and the pre-malignant conditions which lead to these leukemias and lymphomas are the MPS, myeloproliferative syndromes, and MDS, which is a myelodysplastic syndrome. So that finishes my class.